Sexual arousal syndrome, as I told you a minute ago, is an important sign, quite rare, but very specific. Positive tinal test is a trigger zone at the alcohol canal or at the spine, but inducing the same pain the patient complained, which is different of a trigger pain that most of the patients have, especially in women, due to obstetric delivery, which is not so for us, which is a minor criterion. Positive block injection is also a major criterion, and you see all the minor criteria, which are neuralgic pain. We do a questionnaire which is DN4 with a good sensibility, published by Boas-Vera in 2004 that every teams are using at the moment. I told you about the pain in only one territory, and as you can see, and can be surprising, abnormal EMG results and an abnormal US Doppler flux of pudendal artery results are for us minor criteria. Just analyze that now the exploration in pudendal neuralgia. As you can see, we ask for, first of all, usual exploration, and the ultrasound and CT scan and MRI. These examinations of a poor value, especially in PME, but are useful to eliminate some rare reason of pudendal neuralgia, like tumor, especially tumor in the area of the alcohol canal. Concerning the electrophysiological tests, using currently sacral reflexes and pudendal motor nerve latency, unfortunately, after a first enthusiastic work we made in the end of the 90s and the early 2000s, we found that EMG is of low value to help to find the reason of the pudendal neuralgia, especially to say if there is an entrapment or not. Because EMG is just able to tell you that there is a neuropathy, and that's all. And of course, with this diagnosis score that you saw a minute ago, you're able to say that there is a pudendal neuralgia, and you don't need the result of the EMG. This has been published recently by the French electrophysiologist in 2007. The last examination was the result of a reflection we had in our team 2 years ago, because we are still in the research of a good exploration to tell us if the pudendal neuropathy was due to an entrapment, and then the patient could be a good candidate for surgery, because surgery is only efficient when there is an entrapment and compression. And so we said that as long as in the alcohol canal and the pudendal canal there is an artery beside the nerve, if the pressure in the enclosure was higher, we should have reduced velocimetry of the pudendal artery. And that was confirmed last year, and we published this result this year. Let's see now let's talk about the etiology of pudendal neuralgia. As I told you, pudendal nerve entrapment is probably one of the main reasons of pudendal neuralgia, but it is not the only reason of pudendal neuralgia. There is pudendal neuralgia without entrapment, which are the most frequent musculoskeletal issues, but there is also psychological issues, traumatic, tumoral, and we know now that there is also pudendal neuralgia of unknown issues. This is the list of the pudendal neuralgia without entrapment we met in our experience. I told you about the musculoskeletal reason of pudendal neuralgia. They can be primary musculoskeletal dysfunction, but they can be also secondary musculoskeletal dysfunction due to a periodic disease, after gynecological cancer, for example, after periodic dysfunction, and after reaction of special psychological disease. Psychological reason can be an explanation for some pudendal neuralgia without entrapment. We can find depressive state, personality disorders. The explanation of the mechanism is quite unclear, but recently in 2005, a Canadian team discovered a pain proteins, which name is brain-derived neurotrophic factor, could explain some of the reason of this issue of pudendal neuralgia. Other issues are traumatic, direct trauma on the perineum area, obstetrical issues, radiotherapy, but we didn't find no surgical direct trauma. Tumoral compression can be also the reason of pudendal neuralgia. We met in our experience some unusual cancer, progenitor carcinoma, some microglial carcinoma, a few prostatic, bladder and cervix extension, and a fibrous nodule after reaction after trauma of the perineum, and we found also an endometriotic nodule. This is an MRI showing the nodule, which is a fibrous nodule, pushing on the sacrospinous ligament and creating a false pudendal nerve entrapment. So back to the pudendal nerve entrapment now. Two main entrapment locations, as I told you a minute ago, in the claw between the sacrospinous and the sacrotuberous ligament, due to the sacrospinous ligament in the arcuate canal, due to the falciform process. We think that there is a high pressure due to fibrosis, retraction of sacrospinous ligament or falciform process. In other words, we can consider that the pudendal canal, which has been opening here, just to let you to see the pudendal trunk, this can be a high pressure enclosure, and when there is sclerotic retraction of the sacrospinous ligament or sclerotic retraction of the falciform process, then you can have high pressure in this pudendal canal, creating the dysfunction to the nerve. What are the etiology of such reaction of the sacrospinous ligament or of the falciform process at the arcuate canal? We found that post-op sclerosis reaction, post-op trauma sclerosis reaction, post-obstetrical sclerosis reaction, and probably some reaction we don't understand and we call, of course, idiopathic, perhaps primary, perhaps systemic, and why not congenital, because we have a few families with grandmother and mother and some with pudendal nerve entrapment. Okay? Before surgery, the first stage treatment is physical therapy, lifestyle modification, osteopathy, which is the aim is to reduce the pressure on the arcuate canal. We use also 1 to 3 sessions of block nerve injection under CT scan or US or anatomical guidance. Buttocks perineal muscle is also probably more recent for us, but an interesting option before surgery. When all this treatment fail, first stage treatment fail, then you can think to surgery. Surgery is of good prognosis when patient has a good response to drug injection. We find in our statistical analysis 4 prognosis factors: good answer to drug injection, good psychological assessment of the patient, age of the patient under 54, which is a cutoff for us, and oldness of the patient under 7 years. CBUMG and some tests, some preoperative testing that we made are of no statistical value in our results. With surgical procedure, as I told you, surgery is intrinsic only to make the decompression. Forwards is possible to reduce the high pressure in the enclosure. We tried laparoscopic, we tried perineal approach, we tried transgluteal, and now we think that the best is for us is to reach this site and to treat the 2 abnormal ligaments due to sclerosis, and to find an approach which is a transcurricular approach that we have been discovered in 1907, and we have been doing 548 procedures at this day. This is the approach through the vagina in women. This is the approach through a perineum in male. After this approach, you see we do this procedure under endoscopic control, but by the perineal approach. First of all, we separate the sacrospinous ligament from the levator ani. Then this is the entrance to the ischial fossa, and you can see here the arcuate canal. So this approach allows us to reach the sacrospinous ligament and the arcuate canal. Back to another view. This is the sacrospinous ligament, and this is where we are going to make the incision. This is the incision. This is a form of scissor. We use a ultrasound scissor. in order to control the hemostasis, because it's a very delicate region with many arteries. And you see, we are about 2 centimeters of the nerve in order not to touch and now not to see at all the nerve, which is very fragile. The pudendal nerve is not a very strong nerve like you can have in the carpio-medial syndrome. It is a little rubber, very soft, and you have to be very careful not to avoid any trauma. See, when you open the canal about 2 centimeters from the nerve, there is no risk of nerve damages. This is another view at the end of surgery. To evaluate the results, we use VAS and quality of life questionnaire. And this is the result of the TIR procedure on pudendal pain. This is the painful patient. And just after the surgeries, this is 6 months after, almost 70% of the patient are improved, and almost half the patient are improved. The best results are obtained after 1 year of the surgery, with 82% of improvement and almost 60% of improvement. And 2 years after the surgery, some patients are continuing to improve, and we have at 2 years 86% of improvement, and 59% of patients totally cured. In conclusion, I would like you to take home one big message. The only one would be to open our mind and your mind and consider that perineal pain is not a unique entity, and that we have a lack of knowledge, and to open our mind to unrecognized issues of pain like pudendal neuralgia, interstitial issues, vestibulitis, endometriosis, musculoskeletal syndrome, as piriformis syndrome, for example, and all that we need to all work together and to change our mind. Use multidisciplinary management with psy support and not only psychiatric management, as we can see at the moment, because usually after a normal laparoscopy, all the patients are going to the psy, which is not something bad, but it should have been a multidisciplinary approach. Considering the pudendal neuralgia, knowledge of the symptoms of pudendal neuralgia is very important, and for that you have to record the topography of the terminal branches. Too many patients are referred with pain on the buttock, for example, as if it could be a pudendal neuralgia, and it is not. It is more likely a piriformis or muscle reaction, because there is no terminal branch in the buttock of the pudendal neuralgia in the buttock. So that's why I think the medical community has to improve its knowledge on all these symptoms. Pudendal neuralgia is a vast entity. It's not only an entrapment. That's why we have to think to musculoskeletal issues, psy issue, and many other before saying that pudendal nerve entrapment is surgical disease. Surgery is not the first stage treatment. The first stage treatment is physical therapy, Botox, and block injections. Pudendal surgery is only indicated when pudendal neuralgia is due to PNE, and when first stage conservative treatment failed. Non-entrapment issue of pudendal neuralgia have to be eliminated, but afterward, TIR route is an effective approach to open the site of entrapment without neurolysis, as I told you, so no damage of the nerve, and reducing reaction of the muscles in the area, which are usually the worst side effect we can have after the surgeries. TIR surgical decompression can give very impressive results in good indications. Thank you.